I want to start with a sentence a doctor actually said out loud in a room full of Sjogren's patients, because once you hear it, you cannot unhear it. She said Sjogren's should be renamed everything, everywhere, all at once. Not as a joke. As a diagnosis. Because the deeper I dig into this disease, the more it looks less like one condition and more like a case file with your name on it, scattered across a dozen different doctors who never once compared notes. So today we are doing something different. We are not just listing symptoms. We are going into the evidence. The actual mechanism. The actual antibody. The actual reason your heart races when you stand up, or your gut stopped cooperating, or you've been told for years that your tests are normal so nothing is wrong. Because I found the paper trail. And I think a lot of you are going to recognize your own life somewhere in this file. Let's start with the basics, because you need the map before you can read the clues. Your autonomic nervous system is the part of you running on autopilot. It regulates your heart rate, your blood pressure, your digestion, your sweat, your pupils, your bladder. You don't think about any of it. It just runs. And it runs through two channels that are supposed to balance each other, your fight or flight system and your rest and digest system, like a seesaw that's always quietly correcting itself. Before I continue, I built something specifically not for just tracking and doctor's appointment. It is called Symptom Map and it walks you through exactly which symptoms to track not just for Sjogren but also for MS and rheumatoid arthritis. Drop Symptom Map in the comment, and I would send the link for you to access it. There are actually two different ways this seesaw can break, and the difference matters more than you'd think. Sometimes there is real structural damage, meaning the nerve fibers themselves are physically injured or lost, and they simply cannot carry the signal anymore. Other times, and this is the part that gets dismissed constantly, the nerve fibers are completely intact, but something is blocking them from functioning properly. An antibody sitting where it shouldn't be. A neurotransmitter problem. A receptor that isn't receiving the message it's supposed to receive. Doctors sometimes call this a functional problem, and I want to be very clear with you. Functional does not mean fake. It does not mean it's in your head. It means the wiring is there, but the signal is being interrupted. Both types of damage show up in Sjogren's, and often both are happening in the same patient at the same time. Here is the first piece of evidence most people never get told. Sjogren's is not just the second most common cause of autonomic neuropathy after diabetes. It is the single most common autoimmune cause of it. Full stop. Ahead of every other autoimmune disease on the list. If you've ever had a gut feeling that something autoimmune is happening in your body, a little antibody here, a family history of lupus or rheumatoid arthritis there, but nobody could pin it down, Sjogren's needs to be the first name on your suspect list. Not the last. Now here's where it gets interesting, because I want to show you the actual mechanism, the fingerprint at the scene. Your tear glands and your salivary glands don't just make moisture on their own. They wait for a signal. A nerve fiber sends a message, that message passes through a small relay station called a ganglion, and then it lands on a specific receptor called the muscarinic 3 receptor, which finally tells the gland, produce moisture now. In Sjogren's, researchers have found that up to 97% of patients, especially early in the disease, develop an antibody that physically blocks that receptor. The nerve is intact. The signal is being sent correctly. But there's a roadblock sitting directly on the receiver, and the message never gets through. That is not a broken nerve. That is a functional dysautonomia, a communication breakdown, and it means that dry eyes and dry mouth, the two symptoms every doctor has been trained to treat as minor and cosmetic, are actually one of the clearest visible signs that your autonomic nervous system is already compromised. If you have ever been told dry eyes are just dry eyes, comment the word block below, because that receptor story is the piece almost nobody explains to patients, and I think it changes how you see your own body. This is what I call the Sika gap. Sika is the medical term for that classic Sjogren's dryness. The gap is the space between what most doctors are trained to see, a patient who needs artificial tears, and what is actually happening underneath, a signaling failure in a nervous system that runs your entire body. One expert I found put it this way, using this exact framing: if you think of Sjogren's as just dry eyes and dry mouth, you are dramatically underestimating the severity of the disease. And based on the case files I've been piecing together, she is right. Now let's follow the evidence further into the body, because the ganglia, those little relay stations I mentioned, are involved in more than just your tear ducts. Along your spinal cord sit clusters of nerve tissue called sympathetic ganglia, sometimes described as mini brains that filter and synthesize signals before they ever reach your spinal cord or your actual brain. In Sjogrens, these ganglia can become inflamed. And here's the frustrating part of this investigation. There is currently no imaging technology sensitive enough to detect that inflammation in a living patient, and you cannot biopsy it safely. It is, right now, one of the most under-investigated blind spots in this entire disease. Researchers at institutions like Johns Hopkins are actively working to close that gap, studying antibodies that may be attacking these exact structures in both Sjogren's and POTS patients. This is not settled science. This is an active investigation, and you are watching it unfold in real time. There's a related structure worth knowing about too, called the dorsal root ganglia, sitting near the base of your spinal cord. These aren't part of the autonomic system exactly, they handle sensory information, but in Sjogren's they can become inflamed in a pattern called sensory ganglionitis, and it can cause chronic, hard-to-explain nerve pain that doesn't follow the typical patterns doctors are trained to look for. One imaging study actually caught this inflammation on a specialized MRI technique, and remarkably, the inflamed ganglia lined up exactly with where the patient's pain was. When that inflammation was treated, the pain improved. That's not a coincidence. That's a nervous system disease behaving exactly like a nervous system disease, once someone finally looked in the right place. Let's talk about what happens when this system starts failing, because the symptom list is wider than almost anyone realizes. Your heart rate and blood pressure can swing wildly when you change position, which is where conditions like POTS and orthostatic hypertension come from. Your gut can slow down or stop moving food properly, showing up as bloating, nausea, early fullness, alternating constipation and diarrhea, sometimes eventually gastroparesis. Your esophagus can develop its own motility problems, making swallowing difficult, sometimes leading to significant unexplained weight loss. Your sweat glands can go quiet, or work in strange uneven patches. Your bladder can struggle to empty fully, sometimes requiring self-catheterization just to function day to day. And this is the part that genuinely stopped me in my tracks. Your immune system itself is regulated in part by your autonomic nervous system, which means when that system goes off balance, it doesn't just create physical symptoms. It can actually feed back into the immune dysfunction that caused the problem in the first place. It's a loop. The nervous system and the immune system are tangled together, each one capable of making the other worse. There's also a rarer, more severe end of this spectrum worth knowing exists, even if it doesn't apply to most of you watching. In the most advanced cases, the sympathetic nervous system can essentially stop transmitting altogether, causing dramatic blood pressure crashes every single time a person stands, crashes so severe the heart can't even compensate by beating faster, because the signal telling it to compensate never arrives. That's on the far end of the spectrum from something like POTS, where the system is actually overfiring rather than going silent. Knowing where you fall on that spectrum is part of what a proper autonomic workup is designed to figure out, and it changes what treatment actually makes sense for you. If you're sitting there realizing that your gut issues and your racing heart and your fatigue and your joint pain have all been treated as 5 separate mysteries by 5 separate specialists, comment the word tangled below. I want to know how many of you have been carrying 5 folders that were actually always one file. Here's a piece of evidence I did not expect to find, and I think it matters for anyone who has been told they don't fit the mold. Sjogren's is often described as a disease of older women, but researchers at one of the top autoimmune research centers in the country found something remarkable. Roughly 1 in 30 men diagnosed with Sjogren's carries a genetic condition called Klinefelter syndrome, where a man has an extra X chromosome, giving him a slightly different hormonal profile than typical male physiology. This does not mean Sjogren's is rare in men. It means there may be a hormonal thread running through this disease that researchers are only beginning to pull on. Younger patients, patients of every race and ethnicity, patients far from the stereotype, all show up in this file. Close to half of patients, when you ask carefully, can trace symptoms all the way back to their teenage years or their 20s, long before anyone considered this diagnosis. If you've been dismissed because you don't fit the picture in someone's head of what a Sjogren's patient looks like, that dismissal was never based on the actual evidence. Now let's talk about the part of this investigation that made me the most frustrated, because it directly explains why so many of you have been told your blood work is clean, so nothing is wrong. This is what one expert calls the biggest lie in Sjogren's diagnosis. A negative antibody test does not mean you don't have Sjogren's. About 40% of Sjogren's patients never test positive for the two antibodies most doctors screen for. And critically, patients whose primary symptoms are neurological, meaning dysautonomia, meaning the exact symptoms we've been talking about this whole video, are even less likely to show those antibodies. So the patients most affected by autonomic dysfunction are statistically the most likely to be told their blood work looks fine. I also need to walk you through something that trips up even good doctors, the official classification criteria for Sjogren's. It's a scoring system worth 9 total points. 3 points come from positive antibodies. 3 points come from a positive biopsy. 3 points come from measurable dryness on specific tests. You need enough points to officially qualify. But here's the catch nobody tells patients. Those criteria were built to standardize research populations, not to capture every real patient. An estimated 1 in 5 people with genuine, confirmed Sjogren's present without significant dryness at all. And people with neurological presentations, the dysautonomia patients, are disproportionately the ones who fall outside these criteria, even while their disease is very real and sometimes very severe. So when a doctor tells you that you don't meet criteria, therefore you don't have it, that statement confuses a research filter with a diagnosis. Those are not the same thing, and the distinction has cost people years of their lives. When antibodies come back negative but suspicion remains high, the next step is something called a minor salivary gland biopsy, often referred to as a lip biopsy. It's a small tissue sample taken from inside the lip, examined under a microscope for clusters of immune cells attacking the salivary tissue. The result gets reported as something called a focal score, and generally a score of 1 or higher supports the diagnosis. Here's the twist in this part of the case. That biopsy can also come back negative even when the disease is very real, especially if there's been long-term damage that has already turned into scarring, essentially erasing the evidence the biopsy is looking for. One patient in this investigation had her first biopsy come back completely clean. No positive antibodies. No conclusive biopsy findings. She was sick for years, convinced something autoimmune was happening, and repeatedly told she didn't qualify. Years later, a more experienced specialist performed a second, more precisely done biopsy, and this time it came back clearly positive. She had been right the entire time. The tests had simply not been sensitive enough, or performed carefully enough, to catch it the first time. Later still, after years of treatment and healing, a third biopsy actually showed less inflammation, not because the disease was gone, but because scarring had replaced active inflammation, which meant her score on paper went down while her lived experience of the disease never did. That alone tells you how unreliable a single snapshot test can be for a disease that changes shape over time. I need you to hear that clearly, because I know some of you have lived exactly that story. A negative test is not proof of innocence. Sometimes it just means the investigation needs a better witness, and sometimes it means you need a biopsy performed by someone who has actually done hundreds of them, not 2 or 3. There's one more twist in the biopsy evidence file that almost nobody mentions. If you have ever smoked tobacco, even years ago, nicotine stimulates the same nerve pathways involved in this disease and can suppress the inflammatory signs a biopsy is looking for, sometimes producing a false negative result even when Sjogren's is present. It's a strange, almost overlooked variable, but it's documented, and it's exactly the kind of detail that gets missed when a case is closed too early. There's also a stubborn myth worth busting directly, because it comes up constantly. Some doctors will look at a normal inflammation marker, something like a SED rate or CRP, and conclude that means you're not inflamed, so it can't be Sjogren's. That reasoning is wrong. Those particular markers are notoriously unreliable in this disease. They can sit completely normal in a person who is clearly, measurably inflamed by every other standard, and they can climb for entirely unrelated reasons. Relying on them to rule Sjogren's out is a documented, frequently repeated mistake, not a reliable diagnostic tool. Let's move to the part of the file that I think deserves more attention than it gets, the overlap with mast cell activation syndrome. In the dysautonomia community, unexplained rashes, flushing, and allergic-type reactions often get filed under mast cell activation on their own. But specialists who work extensively with Sjogren's patients have observed that a significant portion of their dysautonomia patients also carry a mast cell activation diagnosis, and when the underlying Sjogren's gets treated, the mast cell symptoms frequently improve too. That doesn't mean every case of mast cell activation is secretly Sjogren's. It means if you're managing mast cell symptoms and dysautonomia at the same time, and nobody has ever screened you for Sjogrens, that's a thread worth pulling. Now, I want to walk you through a full case file, because seeing this piece together start to finish tends to make the pattern click faster than any symptom list on its own. A physician, healthy and working full-time, experiences a sudden and dramatic decline. Extreme fatigue. Lightheadedness that leaves her mostly bedridden. She loses nearly 60 pounds in a matter of months due to esophageal motility problems that made eating difficult. Her ears are affected, with sudden hearing loss on one side that turns out to be an emergency requiring immediate high-dose steroids, treatment she had to fight to get, and treatment that saved most of her hearing. Her heart develops recurrent inflammation around it for no clear reason. Her trigeminal nerve, the nerve running through the face, becomes inflamed across all three of its branches, at one point causing a tooth to visibly change color from disrupted blood flow, saved only because she was already on treatment for the underlying disease. Even her vocal cords were affected, one side becoming paralyzed during an attack that looked, to an emergency room, exactly like a panic attack, oxygen levels perfectly normal, until a specialist happened to be watching her throat with a scope at the exact moment it happened and caught the nerve failing in real time. Every single one of these was initially treated as its own unrelated problem. It took years, and her own medical training, to finally connect them into a single diagnosis, Sjogrens, with autonomic, sensory, and cranial nerve involvement all firing at once. If any piece of that case file sounds uncomfortably close to your own folder of unrelated diagnoses, comment the word file below. I read every single one, and you are far from the only person watching who has been quietly building this exact case alone. Let's talk about what recognizing this pattern can actually change for you, because this is not just about naming a disease. It's about access to treatment that would otherwise never be offered. Patients with confirmed Sjogrens-related autonomic dysfunction have access to therapies like IVIG, immune-modulating infusions that some patients describe as genuinely life-changing for their dysautonomia symptoms, even though large-scale clinical trials are still catching up to what clinicians are already observing in practice. Other treatments get chosen based on which system is hit hardest: hydroxychloroquine as a common starting point for many patients, methotrexate for those with predominant joint involvement, and in more severe systemic cases, stronger immune-modulating medications, all weighed carefully against their own risks, because none of these are decisions made lightly. Confirmed diagnosis also means monitoring for real, elevated risks, including cardiovascular disease, certain autoimmune overlaps like thyroid disease and celiac disease, and in some patients, a meaningfully increased risk of lymphoma. This is not information meant to frighten you. It's information meant to hand you leverage, because knowing what to monitor for is how you catch problems while they're still manageable instead of after they've become emergencies. There's a small, oddly beautiful piece of evidence in this file I want to share, because it's a reminder that even in a disease this frustrating, real solutions exist. For severe eye damage caused by chronic dryness, some patients are treated with something called autologous serum eye drops, drops made from a patient's own blood, spun down and processed until only the healing serum remains. One patient described corneal damage that had resisted every standard treatment for over a year, fully healed once she started using her own serum in her eyes. It sounds almost too simple to work. But sometimes the most overlooked answers are the ones sitting quietly inside your own body the whole time. I want to address something else too, because so many of you asked versions of this question in the comments on earlier videos, and that's movement. If you're dealing with dysautonomia, the word exercise can feel like a threat rather than help, because pushing too hard, too fast, genuinely can backfire and leave you worse for days. But the evidence here isn't telling you to force yourself through a normal workout. It's telling you that very slow, very structured, carefully paced activity, sometimes starting with something as small as one length of a pool or a few minutes on a reclined bike, built up gradually over months, not days, has helped some patients meaningfully improve their tolerance over time. The key word is gradual. If you push and you crash for 2 or 3 days afterward, that's not weakness, that's useful information telling you the pace was too fast, and the next attempt needs to be smaller. I also want to be honest about the practical side of this investigation, because knowing the pattern only matters if you know what to do with it. If you suspect this thread runs through your own case, the first move is not necessarily a rare specialist. A primary care provider can check your heart rate and blood pressure lying down, then again after standing, and that simple comparison alone can reveal significant autonomic dysfunction. A tilt table test offers a more detailed, controlled version of that same evaluation. If nerve damage specifically needs to be confirmed, a neuromuscular or autonomic specialist becomes the next stop. And when it comes to Sjogren's itself, remember what we uncovered earlier. A negative antibody test is not the end of the investigation. If your blood work is negative or unclear and your symptoms strongly suggest Sjogren's, a properly performed minor salivary gland biopsy, done by someone with real experience in it, can uncover what the blood work missed. It's also worth asking directly how many of these biopsies your doctor, and the pathologist reading the results, have actually performed. Experience with this specific test matters more than people realize. This is exactly why I built the symptom map for this community. So many of you have told me you freeze up in appointments, unsure what language to use, unsure what tests to actually request, terrified of being brushed off one more time. The symptom map lays these patterns out clearly, so you can walk in prepared instead of hoping the right question happens to come up. If you want it, comment the word map below, and I will send it your way. I want to close with something that stuck with me from this entire investigation. One of the doctors who has lived through this disease herself made a comparison that I can't stop thinking about. She said a diabetic never has to walk into a doctor's office and explain what diabetes is. But patients with Sjogren's and dysautonomia are constantly put in that exact position, forced to become the expert on their own disease just to get taken seriously. That should not be the standard. But until it changes, the best thing any of us can do is refuse to let our own case go cold. The evidence in this file was never missing. It was scattered. A racing heart here. A gut problem there. A tooth that turned gray. A hearing loss that came out of nowhere. A vocal cord that stopped moving. Nobody had connected them, because nobody was looking at the whole board at once. Today, you looked at the whole board. If this helped even one piece of your own puzzle click into place, comment below, whether it's the word file, or the word map, or the word blocked, or just the symptom that hit closest to home. And if you know someone who has been quietly collecting their own folder of unexplained symptoms, send them this video. You might be the reason their case finally gets solved.